I'm hoping this will be sort of a light session where we can have more discussion and interaction. Can I have the slides, please? In this session, we'll be discussing endoscopic correction of reflux. And when we look at the history of reflux disease, in early 50s, it was mainly understanding of reflux, and reflux nephropathy was the issue for many of us. In 60s, people started to understand the anatomy and found out that there was some anatomic deficiency. When you have an anatomic deficiency, of course, the treatment of choice would be surgery, and this was the time most of the children were treated with surgery. Later in 70s, we tried to understand the urinary tract infection and scar formation, and at that time there have been a number of randomized controlled trials, and medical treatment has become an option for treatment. And actually it was shown that with medical treatment, you can actually be as successful as surgery in preventing scars. In 80s, with the use of ultrasound, we were able to diagnose prenatally, and actually we were able to diagnose some of the cases before they will become symptomatic. And later in 90s, we started to use urodynamics, and we started understanding the role of bladder dysfunction on reflux. And in the 21st century, we're in the minimal invasive era, and the most common or the most popular treatment is endoscopic correction, which we're going to talk about. And we'll probably be a little skeptic and critic about endoscopic correction in terms of indications, in terms of technique, and about the substances. I'd like to thank DEXEL for supporting that Satellitensymposium, and we're going to talk about indication first, then the technique, and then later the substances. And I'd like to invite Professor Nijman to talk about endoscopic correction of reflux for all, for some, or...
Do I have to start my own slide? Oh, here it is. Okay. Well, thank you, Serdar, for this introduction, and ladies and gentlemen. I've been asked to give a brief introduction on why we treat reflux in the first place, and for that I also want to go back a little bit into history. First of all, these are my disclosures, and this is an overview of the topics that I would like to address tonight with you. As you're sitting here in the audience, and I would probably expect the same when I were sitting in your seat, to have a simple answer to the question, who do we treat with endoscopic correction? The problem is that there is not a very simple answer. We've had some discussion about reflux earlier today already, and then you could notice that there are different ways of looking at this problem. Reflux is probably one of the most controversial topics in pediatric urology, and one of the men, his name was mentioned earlier today by David Frank, wrote in 1974 that reflux is like an old hat. Now that we have a reliable operation to fix it, it is a boring subject to talk about. About 30 years later, Sir David Innes-Williams wrote a paper in the British Journal of Urology, and then he said, the more that we looked for reflux, the more often we found it. And this was the real launching point for pediatric urology on both sides of the ocean. Here we had a prospect of a surgical operation curing a common complaint. A few things and a few words about the context of reflux. Urinary tract infections are the most common serious bacterial infections in children, and about 7% of all the girls and 2% of all boys suffer UTI in the first 7 years of life. And febrile urinary tract infection is the most common in children under the age of 1. 60% of them will also have a pyelonephritis. 50% of children with spinal nephritis will have renal scarring, and I will come back to that later. Extensive renal scarring is associated with hypertension, chronic renal failure. We also know that about 30 to 40% of all children with urinary tract infection and fever have reflux. And that reflux is a risk factor for pyelonephritis and renal scarring. And we also know from several studies that correction of reflux reduces the risk of pyelonephritis. But on the other hand, we also know that pyelonephritis and scarring may also develop in the absence of reflux. So now for the younger pediatric urologists in the audience, I think it's a good thing to go back a long time, well, not that many years, but following the Second World War, it was found that we had a lot of young men with spinal cord injuries. And about 2/3 of the death in those spinal cord injury wards were due to severe reflux and pyelonephritis and other complications because of the reflux. Initially, about a quarter, 25%, developed hydronephrosis with preservation of renal function. But when they were observed for a couple of years, reflux occurred, and usually high-grade reflux with renal function impairment. And therefore, Hutch concluded that reflux was a grave danger to function of the upper urinary tract, and he developed an operation to correct it. So that is about 60 years ago. A little bit later, in the early 1950s, both Ledbetter and Politano, they developed their operation to correct reflux. And it was at the same time recognized that reflux was not a very easy disease. It was more complex because it also occurred in conjunction with urethroseals, ureteric ectopia, and duplex systems in the patients with urethral valves and the ones that had febrile urinary tract infections. And at that stage, it was advised to correct primary causes first and perform surgery if reflux persisted. Our pediatric nephrologists found out about 40 years ago that the most common cause in a lot of European and American and the United States, most common cause of end-stage renal disease in children was what they called reflux nephropathy. And indeed, 25% of these patients had high-grade reflux, and most of them suffered from urinary tract infections. And in combination with the neurogenic bladders, where we saw that a lot of patients developed hydronephrosis, reflux, renal scarring, chronic renal failure, and death, and that is not only true for the ones with spinal cord injuries, but also with the children with spina bifida. When you put these things together, in the 50s and the 60s, we had a general belief that treating reflux surgically in normal children would save many kidneys and prevent end-stage renal disease. But how successful have we been? When you look at most outcome measures, apart from disappearance of reflux, most people would write about renal outcome as far as function and scar formation is concerned, and the disappearance of urinary tract infections. We now know that so-called renal nephropathy actually represents renal dysplasia in many of the children with high-grade reflux. And therefore, very aggressive treatment will not be very helpful. On the other hand, the percentage of children with reflux nephropathy in the end-stage renal disease group over the years, over the past decades, has virtually remained stable and not changed significantly. We also know that reflux in otherwise completely normal children very rarely leads to end-stage renal disease, and that it is the abnormal kidney that is at risk with pyelonephritis and progressive renal scarring. This is a very, not so-called old paper, but it is a historic paper written by Philip Rensley. I don't know whether Philip is still in the audience, but this was one of his first papers, and he wrote a lot of papers on reflux nephropathy. and the effects of antimicrobial therapy on that. And he didn't do that alone during his London time, because it was Jean Smellie, who also did a lot of research on what actually was going to happen in the future with patients who had reflux and the effects of antibiotic prophylaxis. About 14, 15 years ago, they published a paper in The Lancet with the outcome of 52 patients who had bilateral high-grade reflux and nephropathy. That means that they had scarred kidneys. And one group was treated medically with antibiotic prophylaxis, and the other group had surgery. And as you can see, both groups were equal in size, and after a long period of follow-up, there were no differences as far as renal function is concerned, blood pressure, and many other aspects. So there was no definite benefit of doing surgery considering preserving renal function. A little bit later, and Sarah mentioned that already, from a lot of urodynamic studies and other observational studies, especially when you look at the European side, they were done by the Swedish group in Göteborg, and they were looking at spontaneous resolution, because a lot of patients, the reflux disappeared without surgery, but there was a difference whether you had urinary tract infections or no UTIs, and the same is true in those children who had bladder dysfunction. Spontaneous resolution occurs less frequently than in the ones that have a normal function of the bladder. This is a picture I took from one of the papers of the Swedish reflux group, and here you can also see that there is spontaneous resolution even in high-grade reflux. When you look at older children, when they present with the first urinary tract infection, you can see that spontaneous resolution is a little bit less. From the International Reflux Study, but it was also later confirmed by the Birmingham study, it was noticed that after surgery, surgical reimplantation, the number of urinary tract infections more or less remained the same, but there was a significant reduction in pyelonephritis, that is urinary tract infections accompanied by high fevers. So surgery reduces pyelonephritis, but not necessarily lower urinary tract infections. We've also learned that there is a connection between reflux and bladder dysfunction, and at this stage we realized that the correlation between voiding dysfunction and reflux and UTI is probably very strong, but the correlation between UTIs and reflux per se is much weaker. So reflux is not per se the cause of UTI in children, but reflux is associated with UTIs in children. Bladder dysfunction is very common in children with UTI and reflux. So what have we learned from the past? Most children with reflux will not develop end-stage renal failure. Progressive scarring is mostly seen in children with abnormal kidneys and abnormal lower urinary tract function. And lower urinary tract dysfunction is an important factor in reflux outcome and recurrent febrile UTIs. Just a couple of slides on the Swedish reflux trial that has been mentioned earlier today already. The difference between this trial, or one of the differences between this trial and the RIVER study, is that in this particular group there is a significant number of boys, as you can see here, whereas in the RIVER study the majority of patients, 91%, were females. There were three groups: surveillance group, endoscopic treatment, and low-dose antibiotics. Can I go back here? I don't know. Oh yeah. And of course you can see that there was no significant difference between the reflux outcome in both the prophylactic group and the surveillance group. And of course the endoscopic treatment group was better, but they noticed a 20% recurrence rate at the end of 2 years follow-up. Febrile UTIs primarily occurred in the girls that were not treated nor had antibiotic prophylaxis. That was 57%. Recurrent UTIs were very rare in boys. When you look at new renal damage, new scarring, especially in the female surveillance group, but also in those children that suffered recurrent urinary tract infections. And there were very few new scars in the male population. When you compare endoscopic treatment and antibiotic prophylaxis, there was no difference. Bladder dysfunction was also an important parameter, and that was also mentioned earlier today. When there is bladder dysfunction, there is less spontaneous resolution, more renal damage, and more urinary tract infections. In the RIVER trial, the placebo versus cotrimoxazole were compared. About 50% had bilateral problems, 56% had a bladder bowel dysfunction, and there was a significant difference between the placebo group and the prophylactic group as far as UTIs is concerned, and the difference widened in time, over time. But the prophylaxis was especially beneficial in children that had a bladder bowel dysfunction with an 80% reduction in urinary tract infections. But you had to treat 8 children for 2 years to prevent 1 recurrent UTI. Between the two groups, there were no difference in new scars, and spontaneous resolution was, as you can see on this slide, so about 70% disappeared or improved. So where do we stand now? In most children, surgery is not needed as initial treatment. You have to look for primary causes, both of the reflux and the UTIs, and cure that. Certainly, prophylaxis has a place. We now have the idea that the results as far as disappearance of reflux between open and endoscopic treatment are very little. They're more or less the same. And therefore, the indications for either one form of treatment should have been the same or should be the same as well. But endoscopic treatment is much less invasive than an open surgical procedure. Comparing that to antibiotic prophylaxis, endoscopic treatment has no issues of compliance, and that is one of the disadvantages of chronic antibiotic prophylaxis. Just one slide on antibiotics prophylaxis and resistance, and that is a worldwide problem with resistance rates increasing dramatically worldwide. And that also may mean that resistance may lead to treatment failures and potentially also affect the community as a whole. This is a slide from a couple of years ago where the lower grades of reflux all had antibiotic or no treatment first, endoscopic treatment as second line, and open surgery as third line. So is there a role for endoscopic surgery? There certainly is, but there must be an indication for a surgical correction. That could be that you decide to only do it in higher grades of reflux after 1 year of prophylactic and antibiotic prophylaxis, and for instance in the duplex systems. But also in reflux and breakthrough, febrile urinary tract infections, poor compliance to prophylactic treatment could be a very good reason to do something surgically. But we need to individualize treatment. So as an individual doctor, we have to make a decision based on the kidney status, the bladder status, treat obstruction and dysfunction first. Of course, you have to consider the parents and the child. You have to consider local anatomy, and we want you to stratify the patient according to risk groups. I don't want to go into that, but that has been in the European guidelines. So endoscopic correction is certainly not indicated for all patients with reflux, but if the indication is correct, endoscopic treatment can be used in most cases, provided you have the proper skills to do it and treat the complications as well. Thank you.
Thank you, Rien, for this comprehensive review. So I'd like to invite Guy Bogaert from Leuven, Belgium now. He's going to talk about the technique, and the title of his talk is "Do we hit it or sting it?"
Thank you very much. Good evening. When you, as a pediatric urologist, are looking at a urethral orifice, should you sting it or hit it? That is the question I'm going to try to address together with you as a technique of injection. I like to go back a little bit of like who invented it, and then we go back to, I thought, the first publications on it, and I didn't actually know if this would be the first publication or who did the first test. Was it Prempuri or was it Barry O'Donnell? Because it was in the same journal in '84 that Prempuri published his results in piglets, and Barry O'Donnell published his results in children. However, I found an interesting article in 2010, which was published by two of our colleagues who were working together with Dr. Puri and Dr. O'Donnell, and they said, well, the first injection in Dublin was performed by Dr. O'Donnell in human patients and not in piglets. It was actually thereafter that that was performed. However, he said the first publication was done by Matuszek, which was in Germany in 1981, who published it, of course, in German, and they admitted that it was actually not read in Ireland. Now, what stands for STING? Well, that was Barry O'Donnell that described it, and it stands for suburethral Teflon injection. I like this picture from the BGUI because it shows here very well the layers, and the STING technique is indeed that you inject a material submucosal between the mucosa and even the serosa of the ureter, and certainly between the detrusor muscle. Now, when did we shift from STING to HIT or wherever? Well, HIT stands for hydrodistension injection technique, and it originated and was originally described by Andy Kirsch in 2003, where actually he didn't want to describe a new injection technique, but actually it was a technique to describe the hydrodistension classification of the ureter. And then, of course, you can imagine that if you're in front of such a ureteral orifice that opens up like that, I mean, we're all pediatric urologists, you know, when we see this kind of an opening, we would like to go in there. So, of course, you like to put in there your needle, and that's how he described actually this HIT technique, which is injection into the urethral orifice. Now, in 2008, he described the double HIT technique to further improve his success. Now, I would like to point out here, it's very nice described, what is the double HIT technique? Well, it means you put your needle here at point number 1, that's the intraureteral proximal injection, and you have number 2, it's the intraureteral distal injection, and that's the double HIT technique. Now, how important are those techniques? Can we predict success? Are there any complications? And should we or can we inject several times? Now, to describe the technique, I have focused on 4 publications, and the first one is from Christian Radmayer and his team, where he actually performed fetal development architecture of the vesicoureteral junction, and actually his conclusion is that it is very important for that let's say, good vesico-urethral junction, that there is only one anchor point. Now, back to the technique. Well, Andy Kirsch has described that as of his double hit technique, he is able to achieve a success rate more than 90%, and I met him yesterday. He says he is actually at 93%. Now, are these results always so repeated? Well, not at all, and that's why I like to just also share with you some other studies, and I focused on this quite large study, that the sting technique, even in 2013, was able to achieve an 80% technique, and that was actually identical to the hit technique. And actually, the predictive success rate was the grade and the injected volume. Now, what do we do? And that's actually was a survey amongst United States pediatric urologists, and you can see that over the years from 2003 was mainly the sting technique, then here the hit technique, and actually 2012 and further on, the most popular and the most commonly used technique is indeed the double hit technique. Prediction of success rate, well, it's from this study, I think the increasing grade gives you lower success. The longer you follow up, the more decreasing success rate you will see. It depends on the surgeon experience, and the mount morphology might be a predictive factor. However, less predictive is voiding dysfunction, repeat injection, volume, and abnormal anatomy. So, what about complications? Well, there is, and this is actually, I don't know if there is a publication about it, but it's my personal opinion, that actually right after you've injected these children, and I counsel the parents that it may happen for 2-3 days that the children might have a slight back pain. And indeed, if you do ultrasound, you see a very small and slight hydronephrosis. However, in the long term, and we've seen this and heard this morning in the first session, it's about 1% that actually have a complication of obstruction. And moreover, you can see it at the most in the obstructive and refluxing megaureter. So more and more, this is an important contraindication to inject that urethral orifice. Now, can we inject once, twice, 3 times? I don't know how many times. This Korean study has shown that actually they inject in 7% a second time to improve the result. And this study even has a 4% of 3-time injection. However, I really would counsel you that after a first failure, I think you have to counsel the parents on a very objective way and to tell them really about the success rate of a second and eventually the third injection. Now, what do we do to follow up? Do we do ultrasound, clinic, VCUG? Well, you know, this is one of my pictures of my patients, and I'm always very happy to show this. And I said, you know, wow, look, the substance is right there, it's working. But I don't know if it's still working. The presence, and that has been shown in several articles now, does not predict the resolution of the reflux. And this is shown also in this study together with VCUGs. However, the AUA still recommends after injection that actually VCUG should be performed. Is it really necessary? This is a recent study of this year that actually shown that unless high-grade, very young children, clinical failure, or eventually family or surgeon preference, only then VCUG is recommended. So in summary, what is important for the technique? I think very important is you should create one anchor point, one, not two, one anchor point of the vesico-urethral junction, increase the length, improve that way a valve mechanism, and your success rate will be between 60 and 93%. So again, the double hit technique is the most performed technique. I would personally, and that's my subjective, I would never inject more than twice. I think in the post-op follow-up, it's recommended to do with ultrasound and clinic, and always be very objective and explain everything to the parents when you do this, and that will give you better satisfaction. Thank you very much for your attention.
Thank you, Guy. The next speaker is my colleague from Ankara, Serkan Doğan. He will talk about substances.
Dear colleagues, I'd like to give a brief evaluation of the bulking agents which are used in the endoscopic treatment of reflux. As you know, beginning from the early 1980s, endoscopic treatment have been a significant alternative to the management of reflux. As you know, the ideal injectable should be non-toxic, non-allergenic, and will be stable without migration with minimal local inflammation, and should be well encapsulated. It will be easily injected, but should be viscous enough to prevent leakage from the puncture site, and it should maintain its injected volume. Several agents have been used with these purposes. Some of them particulate, which have the risk of migration, and some of them are degradable, which carries the durability problem. The agents are classified into two as being non-autologous or autologous. First of all, if you look to the autologous materials, they have the advantages of not being foreign materials, however, has the disadvantages of volume loss, and they need to be harvested and expanded before injection. The most studied autologous material is the chondrocytes, and there is one clinical study on this material by Calderon et al. In 2001. They reported a 55% reflux-free rate, which is improved with increasing injections. Teflon paste is the first material used in endoscopic reflux treatment. It has been popularized by Curry and O'Donnell. They reported at least 75% of success rate after the first injection, which increased with the multiple injections. Also, it has been shown that it can be used in higher grade reflux also. It has the advantages of being inexpensive and viscous. However, it requires a ratchet syringe to applicate, and several animal experiments and clinical reports show the distant migration risk because of the small particle size. Therefore, it has fallen out of favor in endoscopic reflux treatment. Cross-linked bovine collagen is a solution of type 1 collagen and type 3 collagen stabilized by glutaraldehyde. It has the advantages of minimal local inflammation, no migration reported. It is easily injectable. However, the 3% of allergy in the population to bovine collagen is a problem, and the other main problem is the durability problem, which is caused by the replacement of injectable collagen with native collagen, and this durability problem is confirmed by two studies that the high initial success rates decrease significantly with the increasing follow-up time. Therefore, most centers have abandoned its use for correction of reflux. Polydimethylsiloxane is an elastomer which is composed of 40% of polydimethylsiloxane plus 60% povidone gel. It has less local inflammatory response than Teflon paste, and it can be easily removed during the open surgery. Although most of the particles are greater than 100 micrometers, unnegligible percent of the particles are less than 50 micrometers. Therefore, it carries the concerns regarding the migration and the negative connotations associated with silicone implants, limited its use in reflux treatment. Good success rates has been reported. More than 80% of reflux-free status has been achieved by injection of PDMS. But as I said, its use has been limited because of the mentioned concerns. Calcium hydroxylapatite is another material. It's a synthetic bone material. There is only one clinical study on this. It's a multi-institutional study. In this study, 66 of patients and 70% of ureters cured, but these rates has been achieved in the center which has the highest patient volume. Therefore, they mentioned the experience is important in this material. Polyacrylate polyalcohol copolymer, namely Ventris, is a recent biomaterial used in reflux treatment. It's a non-biodegradable synthetic material. The particles are flexible. It's easily to inject. The risk of local or distant migration is reduced because of its high size, big size of particles. However, in our institute, our experimental findings and our experiences in 6 patients, because of postoperative obstruction, during the open surgery, we detected very heavy fibrosis and difficulty in dissection during the open surgery. There are 2 clinical studies on Ventris. They report very good results. In one of these studies, 6% of obstruction was reported, and the other multi-institutional study, about 1.2 obstruction was reported. If we come to the dextromer hyaluronic acid copolymer, as you all know, it's a viscous gel composed of dextromer microspheres and in non-animal stabilized hyaluronic acid. It's biodegradable. The dextromer microspheres capsulated by the fibroblast migration and collagen ingrowth. However, it's shown that about 20% of its volume loses beyond 3 months of follow-up. Deflux is the only FDA-approved material in the market today. It's non-immunogenic, it has no malignant potential, no significant long-term effects. It's easily administered. In patients who fail endoscopic treatment, we experience no difficulty during dissection of the ureter. However, the durability of correction of reflux with deflux remains to be proven. There's a huge experience with dextromer hyaluronic acid. In a systematic review, it's reported that the success rate per ureter is about 77%, which decreases with the increasing grade of reflux. As the other colleagues mentioned, Kirsch et al. Describe a technique, alternative heat or double heat, to refine the technique, which promises better outcomes. The long-term results are also satisfactory. The Goran Lekran reported a 7.5 years experience that the reflux-free state decreased from 84 to 74%. But despite these reports, there's also 2 studies which report high recurrences rates, about 20 to 25% in the long-time follow-up. There are 2 dextromer trademarks in the market. They are similar. However, the main difference, at least in Turkey, is the cost, in which in Dexal is 1/3 more cheap in Turkey. And there are two studies comparing these similar to dextromer hyaluronic acid copolymers. In one of them, it was a retrospective study. The results have been compared in two similar groups, and the similar success rates has been reported. In another study, also it was a retrospective comparing Dexel and Deflux. At the end of the follow-up, the similar success rates have been reported similarly. These studies showed us that dextromer size does not affect the surgical and clinical outcome. The positively charged dextromer may potentially have a more durable response, causing more collision tissue formation at the injection site, and maybe cost may be an important issue. There are not so much studies comparing different bioinjectable materials. One of them is by Stradale in 2012. It has a retrospective nature comparing collagen, PDMS, and dextromer hyaluronic acid. At the end of their studies, they reported that dextromer, regarding the reflux-free state and relapse rates and clinical outcome, they reported results in favor of dextromer hyaluronic acid. And the meta-analysis by Elder, they showed that the general overall success rate was about 75% per ureter. It was decreasing by increasing grades of reflux. The second treatment had a success rate about 68%, and the aggregate success rate with one or more injections was about 85%. And they showed that the success rate was significantly lower in duplicated and neuropathic bladders, and it can be used also in failed open reimplantation with a success rate of 65%. They compared the success rates, and they showed that Teflon paste, dextromer hyaluronic acid, and PDMS has similar success rates. However, when you look to the mean injected volume, in Teflon paste, it's shown that the lowest volume was used in PTF Teflon paste, and the highest volume was used in collagen. If we gather all these results in a table, we see that Teflon paste, PDMS, dextromer hyaluronic acid, and PPC has similar success rates. The durability is again similar in these biomaterials. Migration risk is higher in Teflon paste group. When you look to the histologic responses, collagen and dextromer hyaluronic acid seems favorable. As a conclusion, when we look at the success rates, we see that preoperative grade, definition of success, bladder dynamics, anatomic abnormalities, injected volume, conflict of interest of the authors, the learning curve, and surgeon preference are important. And also, as you see, the bulking material is also important. When we try to make an conclusion on the bulking material, we have to consider the FDA approval of the material, the durability, the migration risk, and the cost. And when you will face in the open surgery, therefore it's important, the potential periureteric reaction is again important. As a conclusion of my speech, I would like to say that if there is an indication for endoscopic reflux treatment, and if the surgeon has to choose a material, he has to compare the durability, tissue reaction, and migration risk factors on one arm of the scale, and the recurrence, obstruction, and injectability factors on the other arm of the scale. Thank you very much.
Thank you. Now, this is we are open for discussion. Any questions? Yes.
Nicola Capozza from Rome. Just a comment, not a question.
Okay.
Okay, thank you. So fibrosis and obstruction, in my opinion, don't depend on the type of the material. In my experience, the real obstruction is very rare. and happens regardless the type of the material. Dissection of the ureter can be, in case of surgery, can be very difficult, regardless the material. I have been used Reflux for many years, since 1996, and I have treated more than 5,000 patients, so please believe me, it doesn't depend on the material.
Okay, anybody would like to answer, or I can answer or I can comment on your comment based on my personal experience. I've operated many cases after deflux injection. Generally saying, I hadn't any difficulty with the dissection and the fibrosis. There is, of course, some fibrosis, but it didn't really make the dissection very difficult. I've had a chance to operate 6 cases in the recent a year and a half injected with Vantris. And what I've seen was there was heavy fibrosis, and it was very, very difficult to inject. And actually, in 2 of the cases, I had to dissect or get rid of the distal part of the ureter, and I had to do a sausage. In my view, there is some depends on the substance, but there is also one other issue which needs to be considered, is a double hit procedure. As more double hits are being done, what I've seen is that there's more injection material being injected into the ureter, intramural, and outside the bladder. And that, of course, has some impact on the increased fibrosis. So maybe Guy would like to comment on double hit.
I agree to this last point. Maybe a too deep injection can be the cause of fibrosis.
It can be one cause. Yeah, I would agree with that.
My personal experience is that I haven't done so many redo surgeries, but usually after deflux, it was quite easy to actually remove the substance. Only in one case, I remember, it was quite fibrosis. We looked at it from a histology point of view, and they could only describe indeed large fibrosis, but no other explanation. Really?
Actually, what is reported and what we've seen with Vantris injection as obstruction was in the long term. We've never seen any case in the short term, and I think 2 of those cases that I had very difficulty with were like 2 years after injection. So it's yet early because Vantris is being used quite recently. I don't think we have enough data to comment on this, but we have some initial results which makes us a bit cautious about Vantris causing obstruction.
Of course, there's a lot to be said about this. I think that one of the most important things is, there are 2 things. Most of the residents, they think that doing this kind of procedure is very easy. And it's very disappointing for them to realize that it is not a very easy procedure, and there certainly is a learning curve. And they only understand the real trouble if you do a re-intervention and you can show them where the bulking material, the deposit of it, has actually come to, and it's usually outside the bladder, and that's the reason why the primary procedure has failed in the first place. And especially in children, I think that have recurrent urinary tract infections, when part of the bulking material also gets infected, then you can get a lot of fibrotic reaction, and then the dissection can be extremely difficult. The other thing that I would like to say at this point is that we all started with Teflon paste. Then we went to the collagen, and then we had the macroplastic, then we had the Dexel, then we had the Bulkamid, and we have a lot of other bulking materials that are now available. When you're looking at the real long-time results, that is 20 or 30 years from now, we know very little. And I would urge everybody who's putting bulking material into patients to keep a very good record of their patients and the kind of bulking substance that they're injecting, so that when 20 or 30 years from now, and I will be retired by that time, But my younger colleague will need to be able to retrace all these patients if a problem occurs. Everybody used to believe that silicone was a very safe substance. It turned out to be not so safe, not in all patients, but in a proportion of patients, they developed severe long-term problems. And I think that that is one of the things that the ESPU actually should play a role in making people aware that this could happen in the future. We don't know that yet.
Thank you. Any questions? So maybe just before we close the session, about the substances. I think there are 3 substances available, but Rien was commenting that actually Dexel is not anymore cheaper than Reflux in Netherlands. Is that right?
Well, when they introduced Dexel in Holland, it was very cheap.
Okay.
But that only lasted for about a year, and now it's at the same level as Reflux.
Okay. All right. That's good. It changes from one place to the other. Maybe we can just make a short survey. Who's using Reflux? Okay. Who's using Dexel? Who's using Ventris? Okay, it goes 1, 2, 3. Okay, for the techniques, maybe we can do a small survey with the techniques. Who's doing the old conventional sting therapy? Okay, who's doing the hit technique? Okay, who's doing the double hit? All right, okay, seems similar. Okay, I'd like to thank the speakers for their contribution and the audience